Well, good evening, everyone, and thank you so much for joining us for tonight's webinar, Treatment and Support Options for Individuals with Challenging Behaviors. My name is Siobhán Alvarez, and I am the Executive Director of the Atlanta Autism Consortium. We are a nonprofit organization dedicated to creating collaborative connections throughout the Metro Atlanta autism community. We host free programs and events every month like these and aim to serve the spectrum at large, including parents and family members, adults with autism, researchers, clinicians, and educators. Before we get started, just a few quick housekeeping notes. If you are one of our attendees tonight, please know that your microphone will remain muted, but you can feel free to ask any questions throughout the event by typing them into the chat box, which is located at the bottom of your screen. After the presentations, we will have a moderated panel and then an open Q&A to wrap up the night with our panelists. So please don't worry, any questions that you ask in there, we will make sure that our panelists see. You will also receive an email tonight after the presentations with access to the information that our panelists shared, as well as any of the PowerPoint presentations that they utilized. So don't worry about taking notes. We will make sure that you have access to all of the information. Our panel this evening will be moderated by Dr. Lindee Morgan, Assistant Professor of Pediatrics, Emory University, and Co-Director, Educational Sciences Research Core, Marcus Autism Center. Lindee, would you like to take things from here?
Absolutely. Thank you, Siobhán, and thank you to Siobhán and Laura Aiken for helping us prepare for this one of our many wonderful programs this year. You're in for a lot of excellent information this evening. All of our panelists have just a wealth of knowledge and expertise in their area. We'll be hearing from Dr. Stephanie Trauschke, Dr. Mindy Scheidhauer, Dr. Alexis Pavlov, Dr. Sarah Slocum-Freeman, Dr. Diva Carrion, and Sharon Hines, both representing Marcus Autism Center and the Emory Autism Center. What I'm going to do is introduce each speaker in turn before they give their 5-minute overview of what they do and what services their program has to offer. After that, we will have a moderated panel discussion, and then we will open it up for more general Q&A. And as Siobhán says, please feel free to enter your questions into the chat. I also want to thank my AAC colleague and also an expert in challenging behavior, Nadi Nuhu, for helping prepare some of the moderated questions. So just thinking about this topic, you know, autism itself doesn't cause challenging behaviors. However, most people with autism present with challenging behaviors at some point during their lifetime. And it seems likely that there's some underlying neurobiological processes that contribute to that. You know, and if you think about the core features of autism, including challenges in social communication and repetitive behaviors, these features in and of themselves sometimes contribute to increased anxiety, lack of understanding of a social situation, lack of control, confusion, and these can result in pretty significant behavioral responses. And the challenging behavior is first and foremost often a form of communication. I think a lot about what, and I'm sure all these folks do think a lot about what challenging behaviors mean to families, because even if a child has great language or a very high IQ, it's significant challenging behaviors that are going to keep that child from being able to be included in a regular gen ed setting, or to keep that person from being able to do things independently, like going out in the community and getting a job. And as I've mostly worked with little ones, it's and I'm sure it expands greatly as the person ages. It's challenging behaviors that keep families from being able to function as families and do the things that families normally do, like go to the zoo, go to church, go out to a restaurant. And so these people have dedicated their careers to assisting families with these very important family moments. So I'm going to get started by introducing our first speaker. Dr. Stephanie Trauschke is a licensed psychologist. She's a doctoral level, of course, board certified behavior analyst and licensed psychologist. She sees families in the RUBI parent training and intensive outpatient consult and long-term follow-up programs at Marcus. She works directly with parents and families to address challenging behavior. She's also involved with supervision of trainees and staff. Her research interests include developing assessments and treatments to address problem behavior. At present, she's going to share with us a little bit of information on assessment and treatment of low intensity problem behavior. Take it away, Dr. Stephanie.
Thanks so much, Lindee. All right. Can everybody see that okay? Yes, okay, great. So, Lindee already gave you a lovely introduction for me, but thank you all so much for joining today. Like Lindee said, my name is Dr. Stephanie Trauschke. I'm a psychologist and doctoral level behavior analyst, and I provide services across several programs at Marcus in the severe behavior program to address challenging behavior. Today, I'm going to be specifically talking about challenging behavior in general, and then specifically assessments and treatment of low intensity challenging behavior. So to get us started, what is challenging behavior? When we're talking about challenging behavior, we're talking about behaviors that are challenging or difficult and have an impact on families. So some examples of challenging behaviors may include aggression, things like hitting, kicking, punching, biting, choking, shoving, disruptive behavior, hitting or kicking items like windows or walls, or throwing items like toys or electronics. Self-injurious behavior, hitting, scratching themselves, or someone banging their head on the floor or walls or even windows. Elopement, bolting or wandering away from a caregiver, pica, eating inedible objects. And all of these behaviors may range from low intensity to severe. So if you think about aggression, for example, low intensity aggression might be a light slap to a parent's leg, but high intensity aggression could be tackling someone to the ground and choking them. Or for elopement, a child who wanders away from their caregiver in a grocery store, kind of to the end of the aisle to get their favorite cookies, may be pretty low intensity, but a high intensity elopement might be a child who runs across the street with really busy traffic to get to an ice cream stand. And challenging behavior that we're addressing, it has a really huge impact on families. So sometimes these impacts might be a little bit more obvious, things like physical injury or broken items. But there might be some other impacts that are really big for families in ways that you might not initially think of. Things like increased stress and worries that family have, or tension in relationships between family members as they struggle with what to do when challenging behaviors occur. These families spend a lot of time and resources to address these behavior and accomplish everyday common types of tasks like getting out the door to go to work or school. And often these behaviors lead to challenging accessing necessary services. At times, services in the school or community providers like speech or even medical or dental appointments, which can lead to falling further behind in school or increased health impacts as well. So, what do we do to address these challenging behaviors? When addressing challenging behaviors, we start with an assessment to figure out why it is that the behavior is happening. Challenging behavior is often something that's learned, and it can be considered a way of communicating. So maybe the challenging behavior might be happening to get attention or to get something that the individual wants. Maybe it's happening to get away from something that they don't like. And then once we figure out why it's happening, we often try to teach the individual other ways to get what they want. So for example, if hitting is to access the tablet, we might teach them to ask for the tablet instead of hitting. At Marcus, we see families across a continuum of intensity of problem behavior or challenging behavior. But for families that have low intensity challenging behavior, we often see them in our RUBI parent training program. During these RUBI appointments, we meet with caregivers for 1 hour once a week for approximately 15 weeks. And during appointments, we teach caregivers how to identify why the challenging behavior is occurring. Caregivers practice those strategies at home throughout the week and then come back and report how things have gone. And then at that point, we either modify what we're doing to help it work better or start talking about some new strategies. So some different strategies that we work on include teaching caregivers how to prevent challenging behaviors, how to reinforce behaviors that they would like to see more of, things like paying attention during a learning activity, engaging in more social skills types of activities, how to implement planned ignoring. We walk through how we teach the caregiver how to teach the child new skills, and sometimes more complex types of skills. And then we also talk with them about how to continue to expand those strategies to new environments, new caregivers, and then to continue addressing goals that they may have. So that is my super short presentation. Again, thank you all for coming, and I'll pass it back to Lindee.
Okay, if I could ask a quick question, Stephanie.
Sure.
What if during the beginning of RUBI, the behaviors that parents want to target look a certain way, have a certain topography, but then later those behaviors change and there are new issues to address?
Yeah, so for families that are in already, like we're seeing them for services, if they start to present with some new behaviors, or maybe behaviors are getting more intense or more complicated, we'll see them in RUBI for a little while if it seems like we are likely to make progress. But then we will refer them to another service if we think another service is necessary. So at RUBI, like I said, we have that continuum of services. At Marcus, we have that continuum of services. So we would probably, maybe refer them to the brief behavioral intervention program, or if we think that a community provider might be more appropriate, we would talk with the parents about those different options as well.
Great, thank you.
Of course.
Next up, I'd like to introduce Dr. Mindy Scheithauer. She's an assistant professor at Emory University School of Medicine, licensed psychologist, and doctoral level board certified behavior analyst. She's board certified in both behavioral and cognitive psychology. At Marcus Autism Center, Mindy oversees an outpatient program that uses function-based individualized treatments to target challenging behavior such as aggression and self-injury using parent-mediated models. Dr. Scheithauer also conducts research in this field with several presentations at national conferences and publications and editorial work for leading behavioral journals. She is currently the PI for the largest treatment study to date focused on elopement in children with ASD. Welcome, Mindy. She's going to speak briefly about individualized parent-mediated programs for moderately severe challenging behavior.
Great, thank you for that introduction, Lindee. Everyone can see the slide, okay? Okay, great. So as mentioned, I'm going to be talking about our treatment program here at Marcus that's one level up from RUBI, so more moderate behavior. In terms of what we mean by moderate behavior, in a very eloquent way, we mean not mild and not severe. So these are kind of the behaviors that fall right in the middle. What we really mean by not mild is individuals would be referred to the brief behavior intervention program if maybe the parent needs some coaching in order to work through the behavior. In the model that Stephanie discussed, we're going to present a strategy and kind of assume that the parent can go home and work through that strategy on their own. That doesn't seem likely. If it seems like the behavior is going to be a little too severe for that, then we may refer to this program instead. We may also refer to this program if it seems like a really dense schedule of reinforcement is needed. So for example, in the RUBI program, we might say, okay, why don't you see if every time they come to the table when you tell them to, they get some gummies, see if that works. The BBI program might be more appropriate if the kid actually needs a gummy just standing up, and then for standing up and taking a step, and then 2 steps. So kind of more reinforcement needed. Or if there's a lot going on and it's not really clear what should be the primary focus of treatment, meaning a little more detailed assessment is needed, then the BBI program might be appropriate. However, these aren't the worst of the worst. That's going to be what Dr. Slocum-Freeman is going to talk about later. So we would refer to a more intensive program if the behavior really couldn't be safely managed by one therapist. If the parent and therapist alone couldn't do it. If those really dense schedules of reinforcement aren't successful from the beginning. So if it's kind of, you've tried these things and they don't seem to be working, it seems like a much more detailed treatment is needed. Or if it's just really difficult to figure out what's going on, then that would be a sign that this is not the appropriate program. So the Brief Behavior Intervention Program is another one of our outpatient programs. We try for 10 appointments, 2 hours each. We actually average a little more than that. We do extensions based on therapist discretion, and occasionally we will discharge early, but we try to get the behavior under control in 10 weeks. We do these in different settings. Right now, a lot of them are through telehealth, but in a pre-COVID world, some of them were through telehealth, some are through clinic, and then sometimes we actually go to the client's home. We'll go to the grocery store, we'll go to the park, really wherever problem behavior is happening, try to really meet families where they are. Our therapists are all board certified behavior analysts, and we do have some registered behavior technicians or kind of bachelor's level staff for the program as well. And the goal is to really focus on a few specific challenging behavior goals. What this means is this is not meant to be a global program. You know, we are not discharging kids meeting all of their goals that I would like for the kids to meet across their lives. We're really trying to focus on a pretty specific challenging behavior goal. For the sake of time, I'm not going into it, but there is a slide in the handouts that gives some examples of the types of goals we might address in this program. In terms of treatment progression, so what this actually looks like, usually the first appointment is just getting information, doing an interview, an unstructured observation. We determine those caregiver goals to figure out what we're working towards, and then do a lot of education around the functions of behavior, how to collect data for us, things like that. The next 2 appointments or so are focused on assessment. In the RUBI parent training program, we determine why the behavior is occurring just based on parent report. In this program, we do conduct a functional analysis. So we're doing a much more kind of strategic assessment to figure out why that behavior is happening. However, it is all caregiver led, which is very unique in this program. So we're actually coaching the parent through implementing the assessment, and we are there to watch and take data. We then start treatment development, and from the beginning, we have the parent practicing treatment. This is often a very dense schedule of reinforcement. Meaning, for example, we might say every single time that your kid asks for the iPad, they get it. Or every single time they do a math problem, they earn a reward. Obviously, that's not something the parent can do across the day all the time. You can't have parents giving kids their iPads all day, every day. So what we do is ask them to practice treatment. We say, okay, for an hour every evening, get the treatment material out, make sure it's clear that you're practicing treatment, and then do this with your child. The child's being exposed to treatment in between the appointments, even if it's not quite ready for the parents to be doing it across the board. And then eventually the goal is for the parent to do it across the board. So once we have it so that the child has been taught to wait for their iPad, or they can do a whole math worksheet before they earn reinforcement, then we ask the parent to start doing this treatment across the board. I won't go into this in detail, but we do have some evidence that this program works. This is based on a parent report measure where they rate the child's aggression, both in frequency and severity. What we see in this program is a reduction in both of those things, which is great. And over 80% of our participants are completing the bulk of the program, meaning that while we are asking for a lot from parents, we do find that most parents are able to do what we're asking of them. Last, I did want to include a research plug in here. The BBI program, we have manualized the process that we usually follow in this BBI program, specifically for the topography of elopement, primarily because we have found that elopement is one of those things that some providers feel a little bit lost on, and we want to help with that. Right now, we're evaluating the treatment manual, and we are recruiting kids age 4 to 12 with elopement as a primary concern. So if there are any providers out there or parents of kids with autism and elopement that you think could be appropriate, this is in the slides as well. Feel free to reach out, and that might be a good resource. That's all I have.
Thank you, Mindy. As a person who's a big advocate of parent-mediated interventions, it's so exciting to see this in the behavior realm. And I have to say, I would love to see how a parent-led functional analysis works. Also, thank you for mentioning that the BBI is being offered by telehealth. I know that someone in the chat had the same question regarding Stephanie and RUBI. Please continue to use that chat. These panelists are here, and while they're not presenting, they can respond to your questions. So we're going to move on to the intensive outpatient program, and originally Dr. Colin Muthing was going to present for that, but he is unavailable. So Dr. Sarah Slocum-Friedman has wonderfully decided to jump in. We're going to hear from her twice tonight, but first let me introduce her for this segment. Dr. Slocum-Friedman is a board certified doctoral level behavior analyst and manages intensive outpatient cases in the severe behavior department at Marcus. She coordinates both the intake program as well as the transition program in severe behavior. She's also appointed as an Emory University School of Medicine faculty member. Her research interests include methods for improving the efficacy and efficiency of assessment and treatment of severe problem behavior. Take it away, Sarah.
Thanks, Lindee. Yeah, so Dr. Mething was sad that he couldn't be here today. So I'm going to talk about our most intensive program in the severe behavior program. So we have a lot of patients who end up in that RUBI parent training program or the brief behavioral interventions program that Stephanie and Mindy talked about. But for a lot of the patients that we see, they actually present with some of the most severe forms of challenging behavior that we treat as behavior analysts. And this might include a lot of different things. Some of these individuals engage in really significant forms of elopement and pica, eating things that they shouldn't. These individuals may have to wear protective equipment to prevent themselves from harming themselves. So they may have to wear helmets if they engage in head-targeted self-injurious behavior, or splints to prevent themselves from being able to hit themselves. They may have really severe forms of aggression. So that might be choking, hitting, really intense biting or hair pulling. Most of these individuals require a lot of people to manage problem behavior when they actually engage in severe bursts of problem behavior. And so we see these patients in a very intensive program. It is still an outpatient program, so it's not residential. They do not sleep here, but they are here for about 25 to 30 hours a week. And they're staffed on a really high ratio. So Stephanie and Mindy mentioned that a lot of what they do is kind of mediating through caregivers, where the caregivers are the implementers of the behavior programs. In IOP, we actually have registered behavior technicians who are free staff for one child because of the intensity of problem behavior. And so in addition to being staffed 3 to 1. Sorry, they're coming through to clean our room because it's late. In addition to being staffed at that kind of ratio, patients also unfortunately end up waiting quite a long time for the IOP services at Marcus. They may wait as many as 3 years for our services. Once they start the program, usually it takes us about 3 to 4 months to develop an intervention. And we go through a pretty structured approach to treatment here. So we start with an assessment, just like Mindy mentioned earlier. We spend a lot of time in a functional analysis, figuring out exactly what's going on with targeted problem behavior. A lot of the individuals who come into the IOP program have a lot of different types of problem behaviors. We're not just worried about aggression. We may have kids who present with aggression and self-injurious behavior and elopement. They may happen for very different reasons. Aggression may for one purpose for the individual, self-injury may be happening for another reason. So we spend a good amount of time in assessment, figuring out what's going on. Following the assessment, we develop an individualized treatment plan for that individual. Again, all of this is conducted by those registered behavior technicians, and we do a lot of tweaking to the intervention to make sure it's appropriate for the individual. Then we go into like a generalization phase. So we try to implement our treatments in different rooms with different people. We try to make things a little bit more practical for the client to be successful once they leave Marcus. And then the last stage of this intervention or of this program is actually caregiver training. So we bring caregivers in for really intensive training. Obviously, whatever we do is only going to be successful if caregivers are able to carry out the intervention once we're done. So after we finish doing what we're doing and we show that it works with us, we show that it works with the caregivers. And we actually do a lot of in-home generalization at the end of the admission as well, where we go into the home and we teach the caregiver how to implement treatment in the home, and we fade ourselves out pretty slowly. We actually do this with a very big team of behavior analysts. So most of the people on this screen actually have cases in that intensive program because of the challenge of how difficult these cases are. It takes a lot of hats, a lot of heads in thinking about how to approach these treatments with these clients. And so we work as a team to develop all of the treatments and get the kids, fixed ideally. This program is really successful. We are able to meet caregiver goals for about 80 to 85% of clients, and we're able to reduce problem behavior by a substantial amount, about 80%. Problem behavior never goes away, but we do our best to implement treatment in a way that is successful for caregivers to kind of help their kids continue to progress once they discharge from our program and they're receiving follow-up services. I will leave it at that. It's a lot to describe in 5 minutes, but that's the intensive outpatient program here.
That was really helpful, Sarah. We did have a question that came through about what age do patients age out of the severe program, and Alexis is saying 21.
Yeah, so the challenge there is actually that we are very fortunate to be housed under the Children's Healthcare of Atlanta umbrella, and so we actually have to kind of practice under CHOA, and CHOA's regulation is that we cannot provide services to people over a child's age, which is 21. The other challenge is that a lot of insurance payers mandate coverage for individuals needing these services up until that age. It's a little bit of an unfortunate thing that obviously kids do not stop having autism once they turn 22, but a lot of payers will not provide insurance coverage for ABA. There are other sources of funding that people can look into. That's a longer story than we have for tonight, but we do see patients up until they age out of the system at 21, 22.
Terrific, thank you. And I'm loving seeing all this dialogue coming in through the chat. All right, onward. Next, we're going to have Dr. Alexis Pavlov. She is a board certified doctoral level behavior analyst and a licensed psychologist, also at the Marcus Autism Center in the Severe Behavior Program. She is an assistant professor at Emory University School of Medicine. She's the lead clinician in the crisis admission and consultation liaison programs, which provide behavioral health support to children admitted to hospital emergency rooms for challenging behaviors. Her research focuses on the renewal and resurgence of problem behavior, hospital readmissions for children with ASD and challenging behaviors, and compliance with medical procedures. Please welcome Dr. Pavlov.
Thank you, Lindee. I'm going to attempt to share my screen now and likely sharing the wrong one. All right. Hi, thank you for having me as well on this panel today. And like Lindee mentioned, I'm going to talk a little bit about two new burgeoning programs, the Marcus Autism Center, the Behavioral Health Consultation Liaison Program, and the Crisis Admissions Program. So both of these programs kind of stemmed out of a need and information that's coming out of our healthcare systems about providing medical care to children diagnosed with developmental disabilities and autism in particular. So what we know is that children who are diagnosed with autism or related developmental disabilities require as much medical care, if not more, than their typically developing counterparts. But they are, however, less likely to receive that routine or preventative care or successfully complete medical procedures. A lot of that is likely due to the challenging behaviors that a lot of these kids exhibit. This would include things like, as simple as your regular dental cleaning or a checkup with their pediatrician, all the way up to really advanced medical procedures like MRIs, EEGs, and other medical procedures that might be necessary for these kids. They're also more likely to receive restraint or more invasive intervention, inpatient hospitalization in order to complete those medical procedures. So a lot of the kids that we see even coming through our intensive outpatient program are actually necessitated putting them under full medical sedation in order to do things like get a blood draw or get a teeth cleaning. So from all of that, obviously the cost is very substantial for these families and significantly greater than children in the general population. And all of this combined really leads to a lot of frustration from caregivers and families, and they might avoid medical care just to avoid the strain that it places on the family system. Likewise, we're seeing a lot of this information coming from the healthcare providers that is basically saying, we don't know the best way to care for these patients. And so that hole in the continuum of care was recognized by Marcus and the 2 subsequent programs developed. So the purpose of both of these programs is twofold, one of which is to really focus on the patient, where we're increasing safety and improving the medical care for these children that come through the emergency rooms and inpatient units, especially for those that engage in challenging behavior or non-compliance with medical procedures. And then the second part of it is to help increase the safety of our physicians, nurses, and staff so that those children are able to receive the appropriate medical care. So the crisis admissions program is the newest kind of clinical program offered over at Marcus, and was really designed for these children that end up in the emergency room for some behavioral health crisis, whether that's challenging behavior or an elopement, successful elopement attempt that resulted in needing to seek out emergency services. And these kids get stuck in the emergency room. So I'm not sure how many people are familiar with the residential programs or inpatient crisis stabilization units in the state of Georgia, but they are quite limited on the populations that they will take for primary behavioral health complaints. And autism is actually an exclusionary criteria for the large majority of these facilities. And so when kids go to the emergency room, if there aren't beds available at the limited number of facilities, they get stuck there. And the emergency room is not the place that you want any child to be stuck in for an extended period of time. And especially when we're talking about kids who have routine-oriented behaviors or particular interests that aren't available in an emergency room setting. So the goal of this program was to allow an additional discharge option for these families so that they could discharge from the emergency room home and then come to Marcus, where we have a designated slot in the severe behavior intensive outpatient program for these kids to do a 10-day admission. What that looks like, it's quite individualized and depends on the individual the individual patient who's admitted. But the 10-day admission is outpatient, just like everybody was kind of discussing our IOP program and the BBI program. This is not residential. But during this 10-day admission, we conduct some functional assessment to identify the most likely triggers for the challenging behavior, and especially using that information to develop individualized de-escalation strategies. So that might be if an individual is more likely to engage in a big burst of challenging behavior when they're presented with a demand from their parent, what can we do to help decrease the likelihood that that trigger is either going to be presented, or when it's presented, how can we de-escalate or reduce the likelihood of a crisis event? We also do work with the families directly in environmental engineering for the home. That might be installing locks or deadbolts in the home to prevent elopement, or getting access to some protective equipment for the family. We train the parents on crisis prevention and de-escalation, as well as how to physically manage challenging behaviors and keep themselves safe. Do things like a car harness fitting, or any identifying resources that the family might need to help keep them from utilizing the emergency room as their crisis plan. The consultation liaison service is enveloped in that crisis admission, but this is more so when children are admitted to the hospital, providing them with an individualized behavior plan that focuses on both those safety aspects, as well as helps reduce the likelihood they're going to need to use medical or mechanical or chemical restraint to keep kids safe. We also focus on compliance with medical procedures, train staff in how to implement crisis prevention as well, and then provide some registered behavior technicians who can help serve as sitters in the hospital setting. I'm slightly over my 5 minutes, but thank you. And of course, I'll be here for questions as well.
Thank you, Alexis. This is so stunning. I think any community that has a population of families dealing with autism and challenging behavior would want to have access to something like this. And so it's exciting to see it happen. And I hope that the reach eventually can go beyond Marcus and Children's. It's absolutely terrific. Okay, we're going to transition back to Sarah Slocum Freeman. She's going to speak to us about the Teaching Skills and Transition Program.
Yeah, thanks. So the program that I actually oversee is the Transition Program at Marcus. And the Transition Program has always been a small part of the intensive outpatient program, but we've recently grown it quite a bit. The individuals who complete programs at Marcus in severe behavior, we're really just scratching the surface of what needs to be done for those individuals to be fully successful when they discharge home or go back to school or wherever it is that they're going to go. And so we have a program that's designed for individuals who have kind of successfully graduated from those severe behavior programs, but still really need a lot of work to be able to go into like a school environment and be successful. And so these individuals are in the clinic for 25 hours a week, 5 days a week, 5 hours a day, getting really intensive services, but they're staffed one-to-one. So at this point, we've reduced their problem behavior enough that we can safely staff them one-to-one with a registered behavior technician. And the goal of this program is really to work towards, one, expanding the existing behavior reduction protocol that we have in place to reduce challenging behavior and make it more feasible, and two, develop skills that may not only be beneficial in and of themselves, but really compete with challenging behavior. And so this may be things like teaching kids to tolerate more situations that are not preferred, or tolerate when things happen that are outside of their control. So if an individual has problem behavior that's maintained by access to a tablet, we may need to work on times when the internet goes out, or times when that iPad is not available because it's broken, or whatever else. And so we may work through kind of some more natural challenges that may exist in the natural environment. And then we may also work on things like daily living skills. So a lot of the individuals we work with in the IOP program, they don't want to do things that they don't want to do. And we may work through that challenging behavior in the IOP program, but they may not develop kind of all the skills they need within that domain. And so within the transition program, we can actually focus on tolerating getting their teeth brushed or getting their hair brushed, maybe developing some independence with getting dressed and those kinds of skills. And those skills are really kind of, they compete with problem behavior, right? The more appropriate skills that we can teach kids, the more appropriate behavior that kids have, the less likely they are to engage in problem behavior. Some other things we may work on are communication skills. So a big component of most of our kids' behavior plans is actually a communication repertoire. It may just be that they learn to ask for a tablet and they ask to get a break from academic demands. So within the transition program, we may teach them a lot of different ways to ask for different toys, or we may teach them several different commands for different edible items that they like. And so we may expand that communication repertoire. We may also work on play skills. So just teaching a kid how to appropriately play with stuff other than a tablet, so that they're not only engaged with a tablet from now until the end of time. We also look at social skills, so working on taking turns and losing at games and things like that, which can be challenging for any individual, but certainly individuals with autism. And so this is, again, kind of a 3 to 4 month admission. It's meant to be an extension of the completion of a severe behavior program, but it's really designed to kind of bridge the gap between a really intensive, like problem behavior, challenging behavior focused program into more of a school or a home setting where things are just a little bit more naturalist. That's the transition program in a nutshell.
That's terrific. I've often wondered how someone goes to the intensive outpatient back into the real world, quote. So that's great. That thought is being put into this work. Okay, next we're going to transition to Dr. Diva Carrion. She's a board certified doctoral level behavior analyst and licensed psychologist. She currently has a school consultation program at Marcus, where she works directly with teachers and other school team members to improve educational outcomes for students. Her research interests include training school-based professionals to conduct a full range of functional behavior assessments and to develop function-based treatments for the school setting. So Diva's going to talk about school consult. Thank you. You're still there. Oh, there you go.
I couldn't find the button to unmute myself. Sorry about that. I should have done that before I shared my screen. So thank you for that introduction, Lindee. Like she said, I am Dr. Diva Carrion, and I lead the school consultation program. We provide direct assistance and training for school systems to effectively serve students with educational needs and behavioral challenges, especially those with autism and related disorders. This is just the general areas that we're in Georgia. We are one of the few programs at Marcus that does not have a radius. So we go anywhere that we're asked to go. And that even includes out of state at times. So this little star out here is a school that we serve in South Carolina. And because I know it's probably going to get asked, our services must be requested by the special education director or somebody in the school system. So unfortunately, parents cannot request our services into the school system. It has to come directly from the school system. So like many of the other programs, the staff in school consultation are board certified behavior analysts. I'm also a doctoral level school psychologist. So that just means that I specialized in school age children and their behavior in school, how they learn, all of that. But no matter what service we're providing, our goal is always to increase students' appropriate skills and decrease behaviors that are disruptive in the school setting. We work with students exhibiting a range of challenging behaviors. Nearly all the behaviors that have been previously discussed, we see in schools as well. However, I do believe that there's a limit to what we can do in the school setting. So if I'm working with a student whose problem behavior exceeds what I think should be addressed in the school setting, I will make a recommendation for a high level of support. For example, if a student is engaging in aggressive behaviors that are resulting in significant injury to staff, I would talk about, the level of support that would be needed to manage that level of aggression. We do have 4 levels of service. The first being individual case consultation. Under that service, that often includes functional behavior assessments, assisting in developing a behavior intervention plan, providing training and follow-up on that plan. We'll also complete skill assessments and assist in the development of IEP goals and provide training for teachers on how to implement ABA teaching strategies in the classroom. I think there's a very common misconception that ABA always means one-on-one instruction, but that's actually not the case. And we have steps that we take when appropriate to get a student from that one-on-one instruction to being able to be successful in a group setting, whether that's a small group or large group. We also have classroom consultation. Here we're focused on the whole class. We talk about things like how to set up furniture, how to create schedules and structure that is understandable to the students. And everything we would do for individual cases, except we're doing it for the entire class. And I will also say there's often times where I get called in on an individual case. And I kind of always start it with, well, we need to see the classroom first, right? Because high tides raise all boats. So we will go in and kind of evaluate the classroom and determine if, do we really need to focus on this one student, or are there some systematic changes that need to happen throughout the classroom, see how the student responds to that before doing a specific intervention or evaluation on that one student. That happens quite a bit. Let's see, we also complete professional development trainings on a variety of topics, all related to applied behavior analysis in the classroom, autism, intellectual disability, all of that. And then we also have our BCASE team project, which is the Behavior Consultative Assessment Support and Education team. We just started that in this past year with one district in Griffin Spalding, where we basically have a team of school-based professionals within the district who are receiving training on basically how to do my job, but it's at the district level. So like they'll get my training, reach mastery, and then it's already built in, and we're really just focused on increasing capacity, and then we can kind of move on to the next district. So that's kind of what we do.
That's exciting, Diva. I really love hearing about the existence of BCASE, because I think one of the challenges with behavior services in the school is that sustainability. So if you guys are building that capacity and then able to leave those programs with the tools to do the work, that's really exciting. Okay, and for our final panelist who's going to close out this segment, I'm really excited to introduce Sharon Hines. She has a master's in education and is a board certified behavior analyst. She has worked in the field of autism for the past 25 years with a focus on providing ABA within the natural environment. She is currently the program manager for the behavior support and skill building program at the Emory Autism Center, where she provides treatment and training for individuals with autism and their families and the individuals who work with them. Take it away, Sharon. Thank you.
Okay, well, thank you, first of all, for having me here. I really appreciate it. And like you said, I run our behavior support program at the Emory Autism Center. And like all of you who presented before me, our goal is to increase and enhance opportunities for rewarding experiences, community inclusion, and independence. And to do that, like all of you, again, we work on building skills that are barriers. The lack of skills are barriers to these things. We also work on replacement of behaviors that negatively impact individuals with autism. We provide treatment and training to individuals, like I said, like Lindee mentioned, their families, individuals with autism, their families or caregivers, and really all the people who work with them. We want to make sure everybody who's part of that individual's team is coordinating services, and we're coordinating with them. We work with individuals from early childhood all the way through adulthood, but today I'm going to focus mainly on the services we provide for adults within our program. And as sort of mentioned before, one of the biggest barriers we have to serving the adults in our program is funding. There just really is very little funding for the adults that we serve. The majority of them are individuals who have participant-directed waiver funding, and that typically covers consultative services from us. And we'll also see Medicaid and private insurance, but again, that only goes through age 21. And we have some self-pay individuals as well. But again, the vast majority of our clients are funded through the Georgia waiver program. And when we're looking at the adults that are coming into our program, the first thing we want to do is sort of assess their needs. The adults participating in the ABA program have to have a parent or a caregiver or somebody in their life that's going to participate in the program with them. And these individuals do have those people because, you know, the people that are participating in our behavior program are ones that already need a lot of support. So they're not adults that are able to live independently or semi-independently. These are people that already have supports around them. The treatment should occur with the caregiver and in the environment that the behaviors occur in. So we try very hard, or I should say pre-COVID, we tried very hard to make sure that all of our services were provided in the home or in the community where the behaviors occurred. If the behaviors occurred at Walmart, we would go to Walmart. If it occurred at a restaurant, we would go to a restaurant. Unfortunately, since COVID, it's all been telehealth, and we're hoping to get back out into the community soon because we're finding telehealth is helpful, but not as helpful. And our main focus is really teaching the caregiver new ways of interacting with that adult to achieve the goals that have been identified. So to do that, we begin with a semi-structured caregiver and client interview, and we include the client as much as possible in everything that we do. You know, especially since they're adults, we want to make sure that we're working with them as adults. So we do the semi-structured caregiver interview, and this is a good way of obtaining information that's really important to the client and the caregiver, something that you might not get off a structured assessment. And we as providers, we can never assume that we understand what is best or what is most needed for a particular client. We've learned this time and time again. You know, what's important to one family, one community, one culture may not be something that we understand, but we have to understand that that's important to them and work with them at their level and what's socially significant for that family. So it's very important that we get to know what's really important for that family and what's going to make a positive impact on that family's life. So after we do kind of the informal assessment, kind of getting an idea of what that family's general needs are, what that individual's general challenges are, then we would move on to conduct a functional analysis to really figure out what is this individual communicating with the behaviors that we're seeing. We would also conduct skills assessments and a preference assessment. We want to know, we have a big inventory that we have the parent fill out or the client if they're able to let us know what they like, what they don't like, how much they like what they like, so that we can make sure that, one, if there's things that they don't like, that we're not including that in the program, and that we're including as many things, whether it's activities, items, interactions with other people, we're including those things that are important and that they really like within their plans. Once we've got this information, we do develop a plan, and we review that plan with the client and the caregiver. And oftentimes at that point, we do need to revise it because we're going to sit down with that parent and say, you know, look, in the ideal world, this is what we would do. What does this look like something that you are able to do, or do we need to modify it? And, you know, one thing that we have to keep in mind, we're working with families of older individuals. These parents have been doing this for many years. They're tired. They're you know, adults have a lot of challenging behaviors. And, you know, sometimes we come in and we're like, we've asked them to do too much. So we have to, you know, tone it down a little bit because we'd rather have them have it take a little bit longer to achieve the goal, but have it done in a way that's effective and that the family is actually able to do. So we make sure, you know, that we're collecting data, we're looking at it. Is this individual able to collect the data? You know, do we need to simplify things? So again, keeping that family dynamic, that family's needs in mind with every step of the way. Again, the adults that we see, they have significant skill deficits, especially in the area of communication and engagement. They're oftentimes using augmentative communication devices, or a lot of times they're coming in and they really have no way of communicating other than the behaviors they've developed to communicate what they need to communicate. And so a big part of the program is often enhancing their communication system or just developing a communication system that they can be successful in using. Their challenging behaviors often interfere with their ability to be independent and access rewarding experiences. So we're looking at it, not only, you know, do we need to stop these behaviors from occurring, but if we just stop them, does that prevent them from being able to access what they want? So for example, an individual who will sit down in the middle of Walmart because he doesn't want to leave. Well, we can solve that problem easy enough by not going to Walmart. But then this adult is losing a piece of their engagement that they really enjoy, a piece of their, you know, self-help or leisure skills that they really enjoy. And so we really want to work around how do we get them to be able to go to Walmart and still come home and not put up the fight. Like I said, most of the services are consultative. Pre-COVID, we did offer some telehealth, but every family that participated in the program had to commit to a certain percentage of in-person services because we need to make sure that we're actually seeing what's happening and not, you know, because what's reported sometimes isn't exactly what is happening. And so we want to make sure we're seeing the behavior, seeing the family member implementing the program. Since COVID, we've been pretty much solely telehealth. Aside from a few families that come into our center still. And again, we focus on teaching the families and support staff already in that client circle more effective ways of preventing problem behavior from occurring, teaching alternative skills to problem behaviors, and how to respond without inadvertently reinforcing the behaviors when they occur. And then additional focus is on training the caregivers to teach and reinforce various skills that will help that adult become more independent and better access their community. Again, we want them to, not have to be at home or not have to be in their day program. We want them to go out and do the things they like and participate with their family and the community. So that's really our goal with the adult services that we provide. That's sort of in a nutshell, in a 5-minute nutshell, what we do.
That 5-minute time limit is hard to manage, but this is lovely. And thank you, Sharon, for presenting, specifically on the adult piece. And I mean, I like hearing this emphasis on meaningful participation in the community and sort of these quality of life indicators that we all just tend to take for granted, that you're thinking about those thoughtfully. Okay, we've done great on time. The first hour dedicated to this wonderful snapshot of all the different programs that we have available, and really interesting to learn about the different pieces that are being offered to families. We're going to transition now into the panel discussion. I've got some questions and we may have some more coming through, and I would like to just pose these to our panelists, and then all of you guys, and that can include Nadi, you guys can jump in to dialogue and to respond to these for our audience. So first, I want to start with this question of accessing those services, specifically through Marcus Autism Center. So if I am a caregiver and I'm looking to start services in the severe behavior department, what is it that I need to do?
You need a referral. So if you're a caregiver and you have a child with challenging behavior, you'll have your primary care physician put in a referral to our program, and we can provide the link. It's just like a survey that the provider puts in, and they complete essentially a letter of medical necessity saying that the child needs those services, and that starts the process. That process is lengthy. There is quite a process to kind of being seen for a treatment program. But that's the start. Once we have that referral, we look at various things that we need in order to see the patient. That includes things like an appropriate diagnostic evaluation indicating autism. That is a requirement for insurance payers. It's not our requirement. And some other things along those lines. And we have a program coordinator who works with the family through that process. And then we see them for an intake appointment where we do like a Harry Potter sorting hat, and we put the kid into one of the treatment programs based on their level of need. We always move kids up levels. If we're not seeing enough progress in RUBI or BBI, we can always refer them up to another one of our treatment programs. But that's the kind of gist of the process. And it looks like Lindee provided that link to the referral, or putting in a referral.
Thank you. And that's helpful to know that there's, it's basically one door in, but then the team decides what's the best fit. And, I think in contrast to some of the other services that we provide at Marcus, there really is with behavior an incredible, continuum of different offerings. Similar question specifically for Sharon at the Emory Autism Center. How would someone go about accessing behavior services there?
Yes, so they would essentially just call our main number, and then they would be transferred to Amity Parr, who is our intake coordinator, and she would gather their information, kind of screen what their needs are, and then she would refer them to the specific programs at our center that would be most appropriate for them. And then depending on the program, some programs might be able to get them in right away. Our program, unfortunately, has a pretty long wait list for the behavior supports. But, if it's something urgent, she'll send a message to us, and, sometimes we can squeeze in a short-term kind of individual, but she's sort of the gatekeeper, our intake coordinator to all of the services here at our center.
Thank you. And so Sharon, you mentioned long wait lists, and I think Sarah did as well. I think that's a a pretty common frustration for families in the community. So when that wait list is long, what should families do? What supports or resources are in place that can help during that wait?
Well, for our program, our intake coordinator, Amity, she's got a long list of resources, and she always provides a family with other community resources, Marcus being another big referral of ours, where they can try in the meantime to try and find some help while they're waiting on our wait list.
Yeah, and we do have a few services at Marcus that can sometimes help with the wait. For kids that are on the really on the wait list for our really severe program, we do offer some crisis prevention training, which just involves, how to safely block a hit and block a bite and things like that. Sometimes that's something we can offer families while they wait. And then similar to Sharon, we have a care coordination department that can sometimes help with community providers, meaning just anybody outside of Marcus. The good news is with ABA being covered by Georgia Medicaid, that's a recent change in the last few years. There are a lot more providers getting popped up. It's good for parents to know that you can only have one ABA provider at a time, which does mean, unfortunately, if you started with another provider while you wait and then your number gets called on our wait list, you do have to stop services with that other provider to be seen by us. We don't like that that's the case, but that's the reality of it. However, if you get seen by somebody else and they can fix the problem behavior, we're going to be nothing but excited for you. And then when we give you a call, you can say, we don't need it anymore. And that's great for everybody. So I recommend that families kind of put their name in on multiple wait lists so that you can kind of get services wherever it comes up first. Just know that you might have to make some decisions with providers down the line when you do that.
And I think I know the answer to this, but in case there are individuals out there curious, is it one ABA provider specifically for challenging behavior, or what if you wanting ABA for other reasons?
So for most insurers, it's unfortunately one total. Some private insurance companies do allow for multiple ABA providers, but it's certainly not the norm. So normally what we'll have parents do is put, assuming that they are seeking our services because their current ABA provider isn't really able to treat the behavior, we suggest they put that service on hold. We see them to treat the problem behavior, and then hopefully once we have the behavior under control, they'll be able to make more progress with another ABA provider that is more of a generalist that might be focusing on a little bit of problem behavior, a little bit of skill activation, a little bit of social skills, kind of those broader skills.
Yeah, and I would say most of the patients who like if you have questions about whether you should, give up a current authorization and things like that, we do have, our program coordinator is really good about fielding those caregivers to me because I oversee the intake process, and we can have a conversation about that. I think a lot of times I have conversations with parents about, like, what does the problem behavior look like? What is your current provider doing? Are you noticing decreases already? There's a lot of clinical questions we can kind of go through to get a feel for whether, the current ABA provider may be making enough gains, and just through focusing on some best practices with token systems and timers and things like that, that a lot of problem behavior will decrease on its own versus, it sounds like it's getting pretty intense, and it does require some specialization within the area of severe behavior to treat severe behavior. Just like any field of psychology or behavioral health, there are subspecializations. So if parents are confused or don't know about whether it would be appropriate to give up a current authorization, we're happy to kind of talk through that with them to help make that decision.
Okay. And I know there are a number of different programs, and with respect to Marcus, families come in this one severe behavior door. How do you determine, or what are the criteria for determining if a child and family are going to be a good fit for the program?
I feel like I'm talking a lot. Somebody else wants to say things.
You're good. Go ahead.
So I'll say that I would say we are behavior analysts pretty traditional board certified behavior analysts. We do tend to focus on traditional presentations of autism. Generally individuals who have like very strong cognitive functioning, maybe have kind of issues that may be more appropriate for a cognitive behavior therapist, we tend to refer out of Marcus. We have a couple of providers who we like to refer those patients to. But generally speaking, if an individual is presenting with one of those types of problem behavior, so aggressive behavior, self-injurious behavior, disruptive behavior, we generally are an appropriate referral. There are some cases like the one I just mentioned that are not appropriate. And if kids are receiving services through outside providers, we also can work with providers or speak to providers if we get a release, so that we can make sure that we're getting all the information we need to make a decision about whether or not the referral is appropriate as well.
And in terms of expectations for the families and the things that they need to do to meet criteria, what are some of the considerations there?
In terms of parent variables, so certainly open availability helps a lot. So our wait lists, especially for our outpatient programs, aren't that terrible. They're only a few months long. If you can kind of be seen at 11 o'clock on a Wednesday, you know, in the middle of the day, which I completely get that all parents can't do that. I don't know that I would be able to just leave work once a week at 11 o'clock. But if you can, that certainly helps a good bit. And then all of our programs are parent mediated. So we certainly need for parents to kind of be ready for that behavioral change in themselves. We don't have any programs that involve dropping the kid off and picking them up and problem behavior is better. We just don't have the technology, the methods for that. And everything involves a lot of change in the home. And they're tough programs, they're hard to kind of make it through and to do what we're asking you to do in the home. And certainly that willingness is there. And then I do recommend that parents just, keep a binder or a drawer or a folder of like everything that you have received from your child, diagnostic reports, IEPs, referrals from different people. A lot of times services get delayed because we need paperwork, and that can really slow down getting into services as well. Yeah, to Lynn's comment, we do have one clinician that is providing some cognitive behavioral therapy for anxiety. It's a pretty new clinic, but it seems to be going well so far. They just have a few spots right now, and there is already a little bit of a wait for that program. You also have to, don't want to misspeak, I know that they don't take anybody with worse than a moderate intellectual disability. I think it might be no intellectual disability to make it into that program. And so unfortunately that eliminates a lot of the kids that get referred to us in severe behavior, but that is correct that we are starting to develop a cognitive behavioral therapy clinic that focuses on anxiety. And we are all super excited for that because it's definitely a needed service.
Yeah, and again, I'm not as familiar with that program either, but I do think that they also, like, if an individual is presenting with like a classic anxiety presentation, but also engages in problem behavior, challenging behavior, that may also eliminate them from being able to participate. But yes, we're speaking for Cheryl, I'm not sure.
And Lynn's saying some great referrals are Sean Hurt at hurtpsychology.com and Tyler Whitney at drwhitney.org. Thank you for those. In thinking about caregiver training and parent-mediated interventions, and even if it's not called a parent-mediated intervention, there are some components that the caregivers need to be able to carry on to be able to implement. I'm curious, how do you approach caregiver training, and how do you prepare families to be able to implement in community settings?
I mean, I can speak to for RUBI parent training. It's very, very collaborative. I very much present the information that we have, the different strategies, what I know about the child and the family's goals. and collaborate to develop different strategies. One thing that I try to make very clear for parents is that, I think there's a lot of guilt sometimes in talking about why behavior happens. And so, really taking the approach of like, as you hear my dogs barking in the background, I'm sorry. But trying, the approach really is not that it's the parent's fault, but this is the way that the environment responds when these behaviors happen, and adjusting the way that the world responds to these behaviors to promote other behaviors to help the individual get what it is that they want. So that's certainly that for RUBI.
And just to add a little bit about the intensive outpatient program. So in that program, we do start off first working with the client more intensely and having caregivers participate in caregiver meetings. But as we start developing a treatment that is effective and that we find to be working in the clinical setting, we then have community placements that caregivers have noted problem behavior has occurred. And we try to make it a part of their mission to make sure that we support them in transitioning treatment into those settings. So if grocery shopping is a problem, and that's something you've identified at the beginning, we would make sure that before the admission ended, that we went to a grocery store, we walked around, and then we made sure that you could implement that while completing the task that you need to. So we really work hard to make sure that our interventions are really individualized to the families we work with, and making sure that they are within a reasonable amount of time able to generalize to those settings as well.
And that's a big area that we're always trying to like get better at. I think that like we do our best to kind of outline the intense, like it's just such a big commitment for families, and we realize that. But at the end of the day, like we are not going to be there forever, and so we do try and really like build some buy-in with families. Work with them on like what their true goals are beyond just like, my child, I don't want him to engage in aggression. A lot of times the goals are really centered around like the child being able to play by themselves for a period of time, or the child being able to do things that, most parents that their children do. And so we do try and also focus on like what's important to the caregiver, and not just like as a BCBA, like, oh, we just don't want them to engage in aggression. We try to focus on what's important to the caregiver. Sorry, Sharon, I interrupted you.
That's okay.
It's a big, we don't know how always to get caregivers super involved. It's tough.
And that's, one of the big things that we do is we're working on things, like you said, it's important to the parent. If it's important to the family, they're gonna be a lot more willing to jump in and try it. And for us, the caregiver is always present for all of the services that we provide. So we're modeling it for them, we're coaching them. And for some caregivers, they're going to jump right in and take off with it. And others, they really need to see the child be successful with us first. And they might be a little bit, afraid to kind of step in. And so we can show them, how the child can be successful, and kind of take baby steps with them and coach them through it. Once I know that they're individual or their adults capable of doing that. But again, I think one of the key is focusing on what is important to that family to get the parent to participate.
Yeah, I'll echo what Celine said. I love this sentiment. Parents and caregivers are the most important people in every individual's program, let alone life. Yes. What strategies and considerations do you have for caregivers if they're looking to prevent their child from developing a pattern of challenging behavior? Because I think sometimes we see little inklings of a behavior, and the idea is how do we nip that before it becomes a large thing, a large problem?
So I think that kind of one of the safest recommendations is to promote communication. So, if you can tell why the child is engaging in challenging behavior, find a way for them to communicate for that item. At a really early stage of development, that might mean pointing to the item, creating some picture cards, having them point to a picture, looking up some signs and teaching a sign for the item. And you can physically prompt that. So you don't need to wait until the end of the tantrum if it's going to get really bad, but just, physically prompt them to communicate in some way before kind of giving into the item. Certainly early communication development is really important. And then there are some pretty good resources. You know, Autism Speaks has some resources on challenging behavior that I think are really great at coming up with prevention strategies, things like using timers and visual supports. I don't think it's Autism Science Network. I'm drawing a blank for the name, but there are a few other resources, some through some universities that provide some kind of general overviews for parents. There's some strategies that we don't recommend you try until you have a provider following you, because some of our strategies can make behavior a little bit worse before it gets better. But there are certainly some things like promoting communication and using visuals that are good for most parents to use. I can try to look up the name of the other website if that's in my head.
Yeah, and I would say, like, for a lot of the patients who we see in IOP, like when it kind of gets bad and worse and even worse from that, a lot of times what happens is that caregivers do catch on to that initial like instruction of like, you know, responding to appropriate communication, but they miss the follow-up step, which is actually, like, I describe it as like just being really consistent with rules. And so like if you're going to say that the tablet's not available after 8, then that's the rule, and the tablet goes away at 8 and that's it. Or that there are periods of time in which even if the child does ask for a preferred item, that it's just unavailable. And that's a really challenging thing to implement as a parent. It may be something that like you actually just take the item for, you know, a second. You just say, hey, my turn, you take the tablet and then you give it right back. But over time, you actually increase how much time the child has to tolerate not having preferred items or not having attention or not being able to, you know, do whatever they want to do. And I think that's a big component that a lot of our caregivers struggle with, is that the kids come in with a really strong ability to communicate. They actually communicate incessantly for the things that they want, and they've actually never been taught that that's just not real life, that you just can't have a tablet forever. And so I think that's like a follow-up component that, you know, even in our treatment programs, we start with every time you ask, you get what you want, but eventually we teach children that like that's not forever. And to Mindy's point, that can be a really challenging thing to implement, and it could be something that that you wouldn't want to do unless you had a professional. But, you know, if you're dealing with like a little guy, a 3-year-old, and we're talking about preventive approaches, I think very consistent language with those kinds of rules, and if you say it, then you follow through with it, is a really important component as well.
And I would piggyback on the communication and also add active engagement. And especially with a lot of the adults we see, they just don't know what to do with their time. They don't know how to engage in their environment, how to keep themselves busy. And by teaching those skills, even from age, you're preventing a lot of behaviors from developing, because they're able to find things to engage themselves within their daily routines.
And I would say, you know, if you are worried about challenging behavior, or if you think it might be developing, you know, reach out for help, you know, and talk about all of those wait lists. The earlier you seek services and intervene, the easier it's going to be to address those challenges or get you into other services. And so I would encourage parents, if they are thinking that it might be a problem, that they can always reach out for services.
And I think also being consistent, so I have the school perspective. So I think being consistent as much as possible from home to school can be really helpful. So like what Sarah was saying about like having these rules and being consistent. If we can be also consistent across settings, across adults who are working with the children, that can be really helpful as well.
And I would also say that it's sometimes we get bogged down in the ABA of things and getting things done the way it's supposed to. We want to make sure that that family is having fun with their individual as well. It's so important, because sometimes I think that's forgotten and all of this, you know, collect the data and, you know, follow the routine and make sure you do everything exactly right. And sometimes we'll take a step back and, you know, nobody's having fun. There's something wrong with this. So we need to make sure that's incorporated as well.
Thank you, Sharon. That was a great sentiment to add. So Diva, you mentioned with the school setting. So aside from school consults, do any of the other programs assist with school training or IEP meetings and other school related functions?
Yes. So our intensive outpatient program, we do have a small subset of kids who are actually referred through the Department of Education. So they are referred through their schools. That the school is kind of our primary place that we are concerned about generalizing to. Outside of those few kids, everybody else, all the other rest of our programs, the primary concern is going to be home, but we will collaborate and generalize to the school as well. So what that means is if the kid is not a good fit for our programs other than school consult, if the problem behavior is really only happening at school and the parent is not concerned about behavior at home. However, if we get a successful treatment going for a problem that happens at home and a similar problem happens at school, then we will certainly work with the school to get that behavior program in place. In our intensive outpatient program, that might look like a week or sometimes even a little bit more of us actually going to school with the child and training paraprofessionals and school personnel, and really making sure that treatment is in place consistently across the day in the school. Our other programs, it's probably going to look like 1 or 2 appointments where we will kind of go through the behavior racks and do some kind of basic consultation and training with the school. Sometimes we will go to IEPs. We almost always do in our intensive outpatient program. As the behavior gets less severe, we will sometimes coach the parent how to advocate for their child at the IEP, primarily because those behavior plans are a little bit more straightforward, and we think it's a really good skill for the parent to have to be able to be their child's advocate in that setting. So we'll spend appointment time role playing what parents should do in that setting, but try to kind of have them be independent when we can. So it kind of depends on the case, and it depends on the program. IOP, we're always willing to go to the school if the school will let us in. Outpatient programs, the other ones, it kind of depends on the severity.
And Mindy, you allude to an important point that Diva mentioned earlier, and this is something that I was readily familiar with in my school consultation work back in Florida, is that, it doesn't work for a parent to ask one of you to go to a school, because otherwise, you're an outsider, you're coming in as a quote expert. It's just going to create tension, and the school staff and teachers are going to feel like in a way that they're being judged or spied on. How would you, particularly for families that do have a good relationship with their school team, how would you encourage parents to advocate for their school to request on-site behavior services or consult?
Yeah, Diva might be the best.
So basically, the best way is just to talk to the school about what services are available within that district, advocate for certain supports, and if necessary, you can make them aware that we have a school consultation program. Or you can request, for example, you can request a independent educational evaluation. Usually that is with cognitive assessments and whether or not a child qualifies for an IEP, but that also applies to functional behavior assessments as well. So sometimes we get called in to do that. But I think if you want outside support, the biggest thing is just to talk to the special education director, talk with the school, and advocate for not necessarily saying I want this person to come in and provide support, right? But more so of this child, this student needs these supports to be successful in the school setting. So how are you going to meet that? And the IEP is a legal document. So, you can kind of be on top of that and make sure, are they collecting data? Are they progress monitoring? Who's making decisions as far as whether it's with skill development or with a behavior intervention plan? We shouldn't be staying stagnant. And if you're seeing the same IEP goals year after year, that's a major red flag that the school is not meeting the needs of the student.
That's great information. Changing direction a little bit, responding to a question posed by Tabitha. And I don't know how easy or difficult it will be to answer this without understanding the nature of the regression, but Tabitha is asking, she's wondering about behavioral regression and whether this is a normal thing.
I'll talk. So the easiest answer is yes, it's common. Resurgence or renewal of challenging behavior over a period of time is common, and it really depends on what the cause is in order to determine what the remediation is. So if, like, when we all exercise and we start to lose weight, you start maybe working out less and getting a little lax on your programming. Same thing happens with parents. So parents come in, they're very jazzed about an intervention that's really working to decrease their child's challenging behaviors, and some certain components might fall off, or we might be implementing it inconsistently across caregivers. And so the likelihood that the treatment loses some of its potency or control over challenging behavior is likely during that time. That's kind of an easier fix if it's caught pretty early on, just getting things back on track, getting parents back into the habit or routine of implementing treatment, or trying to tweak treatment a little bit so that it fits more naturalistically into their lives. We provide follow-up services for the families that go through IOP through that age out of through their 21st birthday. So if families stay engaged with us, we are happy to continue to tailor treatment to deal with any of these kind of, integrity failures in order to get people back on the bike, so to speak. Then there are times where behavioral function might shift, right? Whereas before we were engaging in challenging behavior to get access to the iPad. Well, now my, problem behaviors are maintained by getting out of having to do stuff that people are asking me to do. And so it's likely then that your treatment needs to start encompassing things like working on to providing reinforcement for compliance. It's harder when functions shift if you're not sure what's going on, and a lot of the time that necessitates maybe another admission to try and set up separate treatment contingencies for different functions. So yes, it's common. I mean, it's common also that treatment gets a little trickier once you start introducing change agents in the environment that used to that problem behavior used to work with. So for example, once things look really great with a therapist, but we bring grandma in, and grandma's used to giving, the kid whatever they want. And I always pick on grandmas because they're just so sweet, giving their child whatever it is that they want. And then they start implementing treatment contingencies. The likelihood that challenging behavior is going to at first kind of spike or return to rates that were previously seen before treatment is pretty likely. We see that in about half of the cases during those changes. So answer is yes, it's common, but there are some things that you can put in place to mitigate. Wow, great response. You sure you didn't have that drafted ahead of time? Or you've heard that before? Fantastic. You alluded to something that kind of came up briefly earlier in when the question came about, at what point do services at Marcus age out? We've talked about 21. Then perhaps people are eligible to seek services through programs like Sharon's at Emory Autism Center. But what kinds of formal transitions are in place to assist families with that? Because, obviously challenging behavior doesn't stop at the 21st birthday. How do you guys sort of support families through that process?
So probably not as well as we should is probably the answer to that. But the things that we do try to do, we try to make sure that we talk to family about guardianship at, an early age, because we find that that's something that technically falls on the school system to kind of talk with parents about, but often doesn't happen. And so we try to make sure that they have the legal procedures in place. Of course, not every child with autism needs a legal guardian when they turn 18. But because we work with individuals that mostly have pretty significant intellectual disabilities, they usually do. We try pretty hard to get families to think about if they want to be the primary caregiver for their child, throughout adulthood compared to, getting them involved in residential care. In the state of Georgia, residential care is pretty tough to find for children. It's not easy to find for adults, but there are more options. That's still very limited, but more. So starting to get families to think about if that's something that they want. We try pretty hard to have parents advocate through the school system to get kids involved in kind of day programs. Often schools have good connections with those day programs, so that they do continue to have structure during the day and they're not just at home. And then we certainly think about job skills when it's appropriate. So when it is possible that a child could have employment of some sort, we incorporate that into treatment when we can and encourage parents to incorporate that as well. And then we will often refer to the Emory Autism Center and hope that they can take it from there and continue to provide the family with resources.
Yeah, and I think schools are also great advocates to work on transition planning. And so, you know, they are equipped to try to help parents start that guardianship process as well. So if they're not seeing a provider for, you know, challenging behavior at Marcus, the schools should be on that path and journey with families too, to talk about what happens once their child ages out of the school system, which is at the same age they would age out at Children's.
And I would,
sorry, go ahead.
I was going to say, I would add to make sure that all families are applying for the Medicaid waivers early and get that as soon as they can, because they're going to be put on a wait list. And, you know, hopefully when they age out of school or other programs, they're going to have that funding available for additional services.
And it is legally mandated that at the age of 14, there needs to be a transition plan and an IEP. But that doesn't mean that it can't be in there earlier, and we can start thinking about that and creating a plan for that. Many districts have a transition coordinator or manager or something. The titles vary across districts, but basically somebody who's there to help support the transition. There's one school district that I'm in that has a couple of different classrooms for students at different ages or different like cognitive levels to work on what transition to adulthood is going to look like for them. I wish more districts had that, but.
Diva, do you ever need a dog sitter? You're muted, but I'm going to move on. I am going to encourage our attendees, if you have any additional burning questions, please go ahead and submit them in the chat now, because I am coming to the final official panel question. And beyond that, if there aren't more questions, then we will just wrap things up. So fill us in on whether there are any research opportunities available for families that are experiencing challenging behavior, those families having autism, children with autism disorder, autism spectrum disorders. What do we have going on in the area?
Mindy.
I can start, and then other folks can follow up. So as I shamelessly plugged during my talk, we do have a clinical trial focused on elopement. It is a randomized clinical trial for kids that have the presenting concern of elopement. Elopement doesn't really happen on its own, so it is okay if there are some other presenting problem behavior. There just can't be other aggression and self-injury and things that really should be treated, as long as it's kind of okay to target the elopement first. That is, everybody gets treatment in that study. Some people get it first. Other parents get kind of a general education program about autism, and then they move into the elopement treatment. But comparative to the wait list for ABA programs, people get it a little bit faster. And we'll do an updated autism evaluation, which is also a great perk for the family. So if they need an updated evaluation to access other services, that's a way to get that as well. This is kind of problem behavior, kind of skill acquisition, but we also have a project looking at encopresis. So this is individuals who have bowel movement incontinence. We have a program for them as well. Also clinical programs for toilet training for urine. So if the child has toileting concerns at all, we can often help them. But the grant is specifically looking at individuals who do okay with urine, but still have bowel movement accidents. Sometimes these are the kind of kids that ask for a pull-up in order to go in the pull-up. Kids that just, wear a pull-up because of it. Kids that are going in random spots in the houses. Kids that are holding it until kind of they can have an incontinence. So pretty much the full gamut. of bowel movement issues are usually appropriate for that study. We do have a third study that we are looking at children who engage in challenging behavior and non-compliance during medical appointments. This one does not have a treatment branch yet. Right now, we're just seeing if we can collect some physiological data on these kids. Specifically, we're looking at different heart rate patterns. I'm seeing if kids with autism that are disruptive during medical appointments, if heart rate patterns are more similar to what we would expect for anxiety compared to kind of other underlying causes. We are hoping within the next year or two to start a clinical trial of a treatment for that as well. But right now, it's just the heart rate piece of that. And we also have several subjects, several participants for the single subject labs. Sarah, do you want to talk about those kids, or are those all from our wait list?
So they are from the wait list currently, mainly because recruiting through cold recruiting through Facebook and things like that was not particularly successful. But we do have a research lab that's designed to conduct research that we don't necessarily think is appropriate to put clinical patients through. I say that because a lot of us are faculty who have research obligations, and a lot of the clinical stuff we do, we try to write up just to disseminate what we're doing so that other people can learn from it. But there are certain questions, like if we're going to randomize people into treatment groups, things like that, that aren't really appropriate clinically. And so we have special consent for individuals to participate in those studies. A lot of those are clinically relevant and helpful to families. So one of the studies there, we actually do an individualized functional analysis to figure out why the child has problem behavior. They're just randomized into a treatment group as opposed to me getting to pick clinically based on what I think would be best. And so that is available to families who are on the wait list for services. That's just how the institutional review board, how the IRB application has been approved, because we haven't really had luck just recruiting families from the community. But there are a couple of other projects within that lab that look at things like renewal, so resurgence of problem behavior that comes back after time, or issues with treatment integrity. So what happens with problem behavior when we don't implement the behavior plan the way that we're supposed to, because that just happens because we get tired. And so there are some research studies in those areas that, if families want to let us borrow your child for a couple of hours, we would like to continue to answer some important research questions and disseminate that work into the community.
Terrific. And I do want to point out that Alexis posted a link in the chat that lists a number of the different research opportunities. I have not received any additional questions at this point. I do want to point out now that all of you participating will receive contact information for our esteemed panelists this evening. That way, if you have any follow-up questions. And I just want to thank you guys for taking your Tuesday evening to do this. I have learned so much this evening, and it's really encouraging to hear what a wide array of behavior-oriented programs there are out there. So many thanks, and very appreciative. I'm going to turn it back over to Siobhán, and I do believe we want to put in a plug. Is it for next month's program?
It is. So next month for July, we will be having another program on challenging behaviors that we invite you to attend. This one will be on medication and the management of challenging behaviors. So for all of our attendees who have joined tonight, or any that have signed up but were unable to join, you will be receiving an email after this program wraps with more information on how to register for that program, as well as all of the rest of our AAC programs through the end of the year. All the programs that we put on are free, and all of our programs through the end of 2021 will be virtual. As Lindee mentioned, you will be receiving contact information for all of our panelists, as well as additional materials and resources that they shared during tonight's program. If you have any additional questions, you will also receive my direct contact information. Please feel free to reach out, and I'm happy to try to connect you to the right individuals. On behalf of the Atlanta Autism Consortium, I want to have a big thank you to all of our wonderful panelists us tonight, to Lindee for moderating, for everyone who joined. A really big part of what we do are these wonderful collaborative conversations and panels and opportunities like this to share such wonderful information and resources with our community. Thank you everyone so much for attending, and be on the lookout for that email from me later tonight. We appreciate your time and hope to see you again soon.